Good afternoon. Welcome back to the Columbus Metropolitan Club, and welcome to anyone who is new with us today. I'm Mo Wright, Chair of the CMC Board of Trustees and President Raymond Consulting. Looks good to see all of you here with us today. Today's forum, entitled Healthcare and Health Needs, is part of our Healthy Communities series, presented by CMC and our series sponsor, Ohio Health. Today's forum particularly is also supported by the Mount Carmel Health Systems. Join me in thanking them and all of their friends and associates who are with us today. We know that Ohio, under the direction of our Governor John Kasich, has been at the forefront of modernizing access and funding for health care. It's an testament that over 700,000 citizens in our state now have health care through the Medicaid expansion. But despite this progress, we find ourselves at a crossroads in things like ideology and resources, and some days even basic common sense. While our need for health care as a society will not diminish, neither should our will to secure it for ourselves and for those around us. Now let's hear from the man at the forefront of this battle. Please welcome the Director of the Governor's Office of Health Transformation, Greg Moody. Greg? And our host for today's conversation from the State House News Bureau reporter, Joe Ingles. Greg will have opening remarks, and then he'll sit down with Joe for the conversation. Greg, the podium's yours.
Thank you. Well, thank you to the Columbus Metropolitan Club. This has become a bit of a tradition as the state has released its budget for some of the first public conversations on that budget to occur here. I really like this venue because we get to say a little bit, and I'll say a little bit, but then the questions and the discussion are where I think the interest really is. We're fortunate here in Ohio. I'm in a reflective mood because it's been 6 years now in this administration. And when you think back over that 6 years, it's really incredible how much has occurred. The challenges when we first came into office, where our Medicaid program, that's Ohio's public insurance program for low-income Ohioans, it was growing 9% every year, and at that rate, it was swamping the system. So we quickly engaged in a number of reforms, working with many of the folks who I see right here in this room, to get a handle on that. Better coordination, just a smarter management of the program that let us get that growth rate down below 3%. Now that's a magic number, because if your program is growing less than the revenue the state is bringing in, that's a sustainable program. So our focus has been on keeping that sustainable, and because it has been, it's allowed us to extend coverage to more people. And that has been critically important, I think, for Ohio's economy. Now, part of what I think allowed us to do that was the governor's original insight that much of what was going wrong was that folks were going in different directions. We had a Department of Aging, a Department of Health, a Department of Mental Health. Medicaid was physical health care services, all hopefully working together, but sometimes moving in opposite directions. And our mission statement in creating the Office of Health Transformation, which is the unit I head up, is take all those parts and just do this. Because in healthcare, when you make those connections, when you coordinate care, where you avoid gaps, people are better, and as a result, you save money. It's a magical combination in health policy that doesn't exist almost anywhere else. When you do the right thing, you save money. So a lot of what we've done is focus on that. Now, we have a new budget out. There's a lot in there. You have a page on your table that talks about some of the reforms in the budget. What I'd like to do is zero in on a couple example areas of how the budget really is a powerful tool to set state policy and improve the health of our state. So, for example, it's a tough budget. We have been fortunate the past few years that the economy was growing, our revenues were increasing. Recently, we have seen that slow down. When that revenue slows down, it means you have to tighten your belt to stay within what I was describing before, a sustainable growth level. So we are tightening our belt in this budget. And some of the providers, I see some of you here in the room, you're going to want to come talk to us about that because we are tightening things down a little in this budget. But we're doing it so we can continue to invest in these priorities that just really stand out. And I'll mention three. We just put out a new state health improvement plan that identified the most pressing health challenges facing the state. Maternal and infant health, mental health and addiction, the burden of chronic disease. So I just want to mention how we're trying to address each of those in the context of the budget. So for example, infant mortality. Infant mortality is one of these issues where 95% of all black infant deaths and half of all white infant deaths occur in 8 communities in the state of Ohio. Now, the old way we used to do budgeting, we would take money from the federal government for maternal and infant health. We'd divide it up by every community, and every community would get their fair share. But some communities face a much higher pressing need. So in the last budget, we surged our resources and concentrated our resources into those 8 communities that are struggling most with families at risk, to drive better maternal and infant health outcomes in those areas. Now, one of the keys to this is health care coverage, the Medicaid expansion. Most folks didn't understand that prior to the expansion, if you don't have a dependent child at home, you're not eligible for Medicaid. So if you're a woman of childbearing age but without a child at home, you're not eligible for Medicaid. If you're uninsured and become pregnant and haven't been attached to a regular form of care, your risk of a poor infant health outcome is much higher. So coverage for adults is one of the key strategies to holding down infant mortality. So another example, mental health and addiction. So I think everybody knows Ohio, and we're still trying to account for this, Ohio is just hit harder than everywhere else. Our overdose deaths this past year are double any neighbor state. We've been hit really hard by this. We have the #1 highest overdose deaths from synthetics like fentanyl, things that are used by anesthesiologists that find their way into the market. They're cheap, so they get cut into things people think they know how to use, like heroin, but it's something they don't know. And it's very deadly. So we have the highest number of overdose deaths in the country. We're spending $1 billion this year alone to fight that. It's through the Highway Patrol, it's through the Attorney General, it's through our Medicaid program. But again, most of that, $650 million, is in coverage through the Medicaid expansion. Access to coverage to get treatment services to recover. And most of these folks are working. So keeping them at work, in a job, connected to a stable lifestyle to recover from addiction. Critically important that that coverage expansion is there. Here's another example, chronic disease. So in our health insurance program, just like in every health insurance program, a very few people account for most spending. So think of this, 4% of the people in our Medicaid program account for 55% of Medicaid spending. Now, politically, folks usually want to avoid them. They're elderly, they're disabled, they're politically highly charged. But Governor Kasich turned that around and said, yeah, but look, if we kind of drop the ball here, well, that's the worst possible outcome for the most vulnerable group. So, for example, one way you use a budget to address that, most of those very few people were receiving their care in institutions. I mean, for most of us, that's the last place you want to be, and it's the most expensive. So we started creating home and community-based alternatives, taking the money out of those institutions, letting people stay at home longer, it's less expensive, and you get a better outcome. So it's that magical formula of sometimes in healthcare, when you give folks what they want, being well, it actually costs less. So very powerful examples of how you can use a budget document and where you spend to actually drive population health and health outcomes. Now, one other thing I want to mention, I've mentioned the coverage expansion a couple times. You know, in Ohio, we're in a unique position because we've done some evaluation, a fairly extensive interview of the folks who enrolled through the Medicaid expansion. And I have some of the results here, have been really dramatic. So dramatic increases in health status. For example, high-cost emergency department use has decreased. Many people who enrolled in the expansion had a chronic disease, they just didn't know it. 27% were diagnosed with a chronic disease after they were enrolled in the expansion. So they were not receiving the treatment they needed to hold down and manage the cost of their chronic disease, but coverage allowed them to do that. Health status improved for most, 48%, and worsened for very few, only 4%. 32% were screened positive for depression and anxiety. So this is a group who really needs the behavioral health care services. In addition to better health outcomes, it's also created financial security. So, and again, this is 700,000 Ohioans who were previously insured but are now attached to coverage. 89% were uninsured prior to enrolling in Medicaid. So it's not as if they had insurance from some other source and then went on Medicaid. They were previously uninsured. Most reported Medicaid coverage made it easier to continue working and to look for work for those who were seeking work. So we really do see this as supporting work, supporting improving your position with the ultimate goal of getting off public health insurance and back into the private market. Now, all of this recently has been somewhat up in the air. The House in Congress last week introduced a proposal that, at its simplest understanding, eliminates the expansion I was just describing. So what happens with that is uncertain. There seems to be a desire on the House side of the equation to try to save money. There seems to be a desire on the Senate side of the equation to preserve coverage. Those things come into conflict in interesting ways. And how and where does that get reconciled, I think, is an open question. Governor Kasich is part of a group of governors that formed a coalition to identify common ground. It includes expansion states and non-expansion states working together to chart a path. So if the House and Senate aren't able to reconcile their differences, hopefully states are there to say, here's something we think will work. We're going to DC tomorrow. There is a meeting with key Senate staff on Thursday. The Republican governors are meeting Saturday morning. All governors are meeting Saturday and Monday. So hopefully these next few days will be critical in forming some common ground around where the federal health care equation can resolve. There's a lot more to say about that. I'm sure some of you have questions. I think I'll stop here. I'm curious what questions Joe has. But this is an area we may want to revisit in the Q&A. So, Joe.
That is a perfect place to stop because I actually want to ask you about this trip to DC. It sounds pretty interesting. I've been reading about it. And I'm going to guess that Governor Kasich is going to have a little chat with our president about the Medicaid expansion, given what I'm reading. And I guess, you know, my big question for you is there's a lot riding on this Medicaid expansion money. What do you think the governor will talk to President Trump about, and what points should he be making in that conversation?
Yeah. Well, it's true. I believe it's Friday. The governor has been invited to the White House. I would love to listen in on that meeting.
You would.
Healthcare may come up.
I think it will.
You know, we've talked about this a little bit. I think if we were to lay out a strategy, I know particularly in the House there's a desire that you want less of a Medicaid program, and folks should have private insurance instead. And we agreed with that. Ohio has always agreed that the objective is to get people into private insurance. But right now, the turmoil is in that space in the private insurance market where folks aren't attached to employer coverage or some other source of coverage. In the individual market, where the exchange system was created to try to subsidize access to coverage there. And if that's in chaos, we're really reluctant to say, bring down Medicaid coverage for folks to then go into chaos. So I think start with those insurance market reforms, stabilize that environment, because then if that's a stable option, we'd love to bring down Medicaid eligibility levels. For example, right now at 138% of Medicaid, you're eligible, or of poverty, you're eligible. Well, you can bring that down to 100% of poverty, because from 100% of poverty and up, you have access to subsidies in the private insurance market. So that's the kind of thing where Congress could roll back Medicaid some, let other states come up to that lower level, but it really requires having a stable insurance market to be able to do that.
Well, following up, are you hearing that kind of talk out of Washington? Are people realistically considering that?
The challenge, I think, you can tell I'm measuring my words. I think the challenge in the federal environment, and it goes all the way back to the creation of the Affordable Care Act, where that occurred in a fairly partisan environment, where from the beginning it was cast as you're all for this or you're totally against this. And folks were never really allowed to say, like our governor has said, well, I like this part, but I don't like this part. Or maybe I have other ideas. Where's my flexibility to test other ideas? So it's always been cast as all or nothing, and we're still a little bit stuck in that. I was hoping that we would be in an environment where the coverage gains were in place and we could critically look at the things that really do need to be repaired. Because, as I just mentioned, the individual insurance market is not stable right now. And it's not real bad in Ohio, but in some states, it's really falling apart. So how do you have a more nuanced discussion to focus in and repair? So the coalition we've put together is actually working in that space. So if the House isn't able to find something to agree on, and the Senate is wanting to somehow keep some level of coverage, can a group of governors come in and say, well, here's a practical way that might reconcile some of those differences? And so that's what we're working on.
When Governor Kasich expanded Medicaid, one of the selling points that he made was that the feds had pledged to pay 90% of the expansion cost up to 2020. Now, he said if federal support ever falls below to make the expansion a net loss to Ohio, that the state would opt out. Is this still the case? And if the ACA is actually repealed, or the Medicaid expansion is repealed, will the state opt out and no longer pay for Medicaid expansion?
Yeah. You know, the governor is a former budget chairman in the U.S. House of Representatives. So we actually have a lot of, we share the objectives of the House to save money in the program. And we think there are reasonable ways to do that. So for example, if you roll back the eligibility level from 138 to 100, there are some versions of that that could save money. We believe there are flexibilities the state can use. For example, in Ohio, we've worked with private sector managed care plans to hold down cost. Our growth trends are lower than many states because we have a very well-coordinated, well-managed environment. Other states are growing faster than we are. So are there strategies there where states can get the flexibility they need to further contain cost to then avoid other types of cuts? Now, the key on the 90%, I think, is if over a long period of time there was a new deal, would states make decisions to do the expansion anyway at a regular match rate if they could plan ahead to get there? I think that's a fair question. But so far, everything we've seen is an abrupt stop of the enhanced match, which for Ohio would mean coming up with $1.5 billion on a moment's notice. Impractical in the context of how state budgets work. So that's another part of this discussion. Instead of kind of an immediate moment in time, how does this play out over time? Because our insurance markets want a stable path, states want a stable path. How do we create that stable path?
But do you think that they're realistically going to be able to do that? I mean, that sounds like a lot.
It is possible to do.
Okay. One of the reasons that Governor Kasich fought so hard for Medicaid expansion was he said the hospitals needed the reimbursements, and without them, smaller hospitals might be faced with closure. If the feds cut the Medicaid expansion money, will the state be doing anything to help the hospitals with their bottom line to make sure that they don't close their doors, those hospitals that are vulnerable in the smaller areas predominantly?
There are about 8 hospitals I see here, and I'd be very curious to know. Let's talk about that a second. First, I would start by saying the governor's view on that was somewhat broader, that when you have a group that's uninsured but receiving services anyway, that's a very inefficient way to do that. Because if you don't have a regular attachment to primary care, you let things go and now something's really serious and you're in the emergency department, it's just the worst way to handle that. So part of it is when you have folks connected to coverage, you're able then to get the right care at the right time to hopefully avoid other costs later. So that's the real objective of coverage. And if you don't have that coverage, well then those individuals are showing up at hospitals. The hospitals are not being compensated for that care. And in the old system, think how strange this is. Because you didn't get paid, you got a special payment from the federal government because you didn't get paid. But it was only about 1/3 of the cost of the care you provided. Well, Medicaid coverage is much better compared to that. And that additional resource capacity, I think, is what the governor was talking about and hospitals talk about, of how important it was, particularly with rural hospitals, to really stabilize that environment. Now, I've got to say, hospitals, over the past 4 years, those gains equated to about a 37% increase in spending through the Medicaid program. This next year, they were due to go up another 7%, and our budget holds them at a 5% increase. So technically, that's a reduction. Instead of getting a 5% increase, they're getting or a 7, they're getting a 5. So, and then we actually take it down another % in the second year. So I want to be clear that even as we're all working together to create this new capacity through the expansion, we also have a challenging budget where we have to live within our means. And that's why I said I'd be interested to see how the hospitals answer this, because for the expansion, probably against some of our reductions, we have to work together to make sure that's a workable result within Ohio's budget.
But if the feds pull the money out, that would make that even harder to do, right?
Devastating for hospitals, devastating for the state budget, devastating for Ohioans.
And when you say devastating, can you elaborate a little bit on what that might mean for rural communities that the hospital is just barely hanging on? And they don't have a lot of health care in some of these communities either. I mean, as far as doctors and specialists, routine kind of health care, they don't have it there. And they're really, saying we need this help. So would that be, when you're talking devastating, are you talking about those folks, and what are you talking with there?
I think you just answered the question. Yes, all of that. All of that. And often, particularly in a rural community, the big stable employer in that community is often the hospital system. So in addition to just access to care, and so what do I mean by devastating? If my family was in a community that had to travel 40 minutes to get hospital care, I would say that would be devastating. If many of my neighbors are working in that hospital system, that because the financials go away, it's not there anymore. So there are a lot of different ways to define that.
Do you think that we will see basically healthcare deserts out there where there are no longer hospitals or enough doctors to take care of the need if the Medicaid expansion is pulled?
No, because I have confidence. I think there are governors and legislators in both the House and the Senate who have a responsibility to think this through, and I think a path will present itself. So I would not speculate on everything that could go wrong. We're focused on getting out there, weighing in to raise a concern about what could go wrong, but what we're looking for is a path.
Okay. The governor says Medicaid expansion is helping to fight the opioid epidemic. You alluded to it when you were over at the podium. Can you explain how how that's working and what might happen with the uncertainty of funding right now?
Yeah. So this is a complex area, and we didn't anticipate the opiate crisis. But we did anticipate that there needed to be significant reform in this area. And here's why. In the old system, Medicaid health coverage provided for physical health care benefits through care coordination, through kind of the normal provider system, doctors, hospitals. And then over here, almost as if it was in a separate world, we had behavioral health care, totally separate, funded through local levies, where they would use those local dollars to get access to Medicaid money to cover services, but in a fairly separate system. So I have untreated diabetes related to my mental illness. Well, I'm over here for the diabetes, I'm over here for the mental illness. It doesn't make sense. So we very early on started to thinking about how do you treat the whole person and bring those services together? Well, the first step in our first budget was elevate that funding requirement away from local levies to the state. So now the behavioral health benefit is paid for at the state. That then let us say, okay, now instead of the old system that was kind of a one-off, let's recode this to just fit normal insurance standards. Okay, now if we have a behavioral health insurance package, let's combine those benefits with physical health care and have one benefit for individuals. And now let's take that benefit and put it in managed care so we can coordinate the whole thing. So this budget takes that last step. First budget, elevate. Second budget, recode. This budget, move into managed care. So we had a vision from the beginning. I would say that preparation and that being ready is now what allows us to have this greater capacity to respond with treatment and services in response to the opiate epidemic. And by the way, that's true for everything. I mean, there's such a temptation. Infant mortality is like this too, and I've got to say, where we see communities doing well, they get together and plan and coordinate, and one of the best in the state is right here. I mean, and I know several of you in the are there folks here who have been working on that initiative here in Columbus? Go ahead and raise your hand. I mean, yeah, exactly. I mean, there's real leadership here in addressing that issue, and I think some of you would agree with this, there's this temptation to do these one-offs. Give me a pot of money to address this one specific thing. Well, the way to address infant mortality is to have better access to primary care, and to have better care coordination, and to surge resources into the neighborhoods that need it. It's an infrastructure challenge, not give me one little grant over here to do something specific. And we need to get away from this kind of disease of the month thought, because if we have better access to primary care, well, we'll do better on infant mortality, we'll do better on the opiate crisis, we'll do better on every public health challenge.
Mm-hmm. Very good. Well, I need to let you know that in a few minutes we will move to audience questions. So just get prepared for that. But let me first ask you a final question here. Governor Kasich has talked a lot about focusing on staying healthy. And you talked about it over at the podium, some of the initiatives that have been taking place here. Do you think that are they going to continue under Medicaid expansion in the future? And are there other things, is there a wish list, a need list out there that you'd like to see tackled in the near future to deal with some of these problems, even more for opioid abuse or for infant mortality?
Yeah. Well, the way I'd translate that is, it is true you get what you pay for, you know, and the way we have paid for things in healthcare, it's a fee for every service. So the way you make money in the system is just always provide more service, whether or not it's keeping a person well or not. And the temptation is not provide the low-cost primary care service, it's provide the high-cost specialty service. And because of how we pay, the whole system kind of naturally pushes folks up into that highest cost territory. So we've, for several years now, been working with commercial insurance companies to flip that around. And one example, it's in primary care. Aetna, Anthem, United, Medical Mutual, all of Ohio's Medicaid managed care plans, we got together and we went to the best primary care practices in the state and we said, look, what is it that you do that you know keeps people well and avoids other costs? And they identified very specific things. Things like 24/7 access to primary care. They spend different amounts of time with different people. If you're really sick, you get 45 minutes. If you're really healthy, they kind of encourage you not even to come in. Just do a telephone consult. So these strategies that keep people well, we then said, okay, how do you get paid for that? They don't get paid for that. What they get paid for is when that person comes in, they get paid for that visit. And if you do some things while they're there, you get paid for those things you do. Think how bizarre that is. So instead, we now, starting in January this year, we have 92 primary care practices where we say, look, if you do these activities we know keep people well, we'll just pay you more. And then at the end of the year, compared to what we would have expected to spend, if you save money and hit all of your quality targets, you can't just not spend money, but if you're doing things that really keep people well, half of everything we save we'll share with you as a bonus payment. That's potentially significant resources flowing back into primary care to do the right thing. So now you've created a financial incentive to keep people well. And if you're avoiding other high costs, it doesn't mean you just lost that money. It means your money is coming to you in another form as a reward for keeping people well. That's transformational. Ohio is in the lead on this. States are perfectly situated to do this work. We're kind of a neutral convener because it takes getting all of the health insurance plans on the same page. It takes getting the hospital and doctor and provider systems kind of open to the idea. And then really you're matchmaking these special value arrangements to try to reward value. That's good work. And that's what we're working on here in these last 2 years.
So do you want to take that a little farther, or is there something else you want to do with that?
We're queued up to do it. Like I say, the first 92 primary care practices are getting paid more right now for doing the right thing. And starting in January 2018, we're going to open that to any primary care practice in Ohio that can meet those activity requirements. And then on the specialty side, it's a little different. We've created performance measures of episodes of care. We look at high value, low value providers and what they get paid. The high value, low cost, high quality providers, we're sharing money back with them because they're doing the right thing. And the providers that are high cost, in the next year's reimbursement, we're taking that money back away from them. So there's a risk model where there are winners and losers. We have 40 high cost episodes of care where we're doing that. So this is something we're engaged in right now. The interesting thing too, and this is a little preview, the performance reports to show who those high value and low value specialists are, we have that. We want everybody to have that. And we just want to post that online so everybody can start making their own judgments about who's high value and low value. So that work to generate that information then creates, I think, a powerful tool to get better information into the community. So then, as a primary care person, if you're rewarded by holding down the total cost of care and you can refer your patient to somebody who's high value, low cost, you just made money. So that's a very, very powerful conversation. You can see this is something I'm passionate about, so I'll just stop there.
Okay. Well, it's the CMC's tradition to take audience questions, so the microphone is over there. Please state your name and ask your question, and we thank you in advance for not making long editorial comments. So let's proceed with the first question.
My name is Kermit Whitfield. I'll get the pump primed here for anybody else who wants to stand up and get a question. You mentioned earlier that the ACA was kind of a all or nothing, or it was perceived as all or nothing when it was first passed a few years back. I was wondering, what are the key things as we're entering a repeal and replace time frame? What are the key things that you think could be fixed about the ACA or could be put into a replacement that would make it much better?
Yeah. Well, and if you're interested in some details on this, the governor wrote a very detailed letter to Congress that we have on our OHT website, right on the front page. I think it's like nine pages. So it really goes into some detail on this. But I think he would focus first on the insurance market, where in Ohio, we actually had a pretty stable, robust insurance market as it was. A lot of competition, a lot of choices of plans. The problem is for very low-income individuals, it was just too expensive for them to afford themselves. In the Affordable Care Act, what happened was a whole series, the logic was, look, if we're going to subsidize the insurance you have, then we're going to have an opinion about what that insurance is. And the federal government created a whole set of regulations around the insurance market, which was an unprecedented federal action to take over what had been traditionally a state-regulated market. So, for example, there are age rating bands, where if you sell a plan on that's subsidized with federal money, whatever your low-cost plan is, your high-cost plan can't be more than 3 times that amount. If you think what happened for a lot of folks who were paying a whole lot, a few folks saw their premiums come down. But on the other end, there were a whole lot of healthy people who were paying less. They saw their premiums go up. So that's one example of, is 3 to 1 right for Ohio? You know, we were thinking maybe it should be 5 to 1. The point is, we think Ohio should choose. In another state, that may be working just fine, and they should be able to choose that. So anyway, it's that space in the insurance market related to essential health benefits, related to age rating bands, related to how some of the subsidies work. We'd start there, I think, with the repair.
Okay, the next question.
Thank you very much. I'm Amy Claybin, Principal of Strategic Opportunities. You said a lot of very interesting things. You said that you save money in health care when you make connections. Being well costs less. You need to not only address issues one-off, you need to address them holistically. Dr. Megan Sandell spoke here a little over a year ago, talking about housing as a vaccine for children's health. There's a lot of research that's been done showing that when families live in a safe, decent, affordable home, their health will improve, both physical health and mental health. What can we do to address that here in Ohio? Medicaid is allowed to use funds to pay for housing. And so we know that if we can get people into safe, decent housing, people will feel better. And I'll make one statement about lead. What we're doing in Ohio is children are the lead testers. Medicaid funds will come in and remediate the home when a child has been tested positive for lead. But we don't go in and test for lead in the houses. We don't go out and remediate that. Children are sick with asthma. Oftentimes it's a house that's the problem. So we give them medicine, send them right back to the home. And then how do we expect kids to really excel in school when we're medicating them for things that we can deal with housing? So thank you.
Yeah.
Oh.
Yeah, I mean, what you're describing is really important because by the time you're there with a doctor in a clinical setting, very little of your health is determined by what happens in that half hour you're there with the doctor. Almost everything about your health is determined in your life before you got there. Some of that is of your own choosing. If you smoke, you're not going to be as healthy. So some of it is choices people make, and there are things we can do to encourage healthy choices, not unhealthy choices. Many of those things are in the environment. If you're in a house that is unsafe, has poor air quality, and that makes you sick, that's a problem. And you're not going to fix that in the clinical side of the equation. Now, one connection I'd make is think about this. If you're a primary care doctor and you're financially rewarded for holding down the total cost of care, and you know you have little impact on that total health, but there is something in the community, social services that are available to individuals that can improve their health, you now have an incentive to get that patient connected to those services in a way that keeps them healthy. So if it holds down their total cost of care, you just got a bonus payment. Now, there's not a real sensitivity to that. It's, you know, I've seen you, I've done my thing, I got paid, and now you're back in the community. The practices that do really well, like a large practice may have a social worker actually on their staff to be able to work with a family to say, hey, we're seeing some things here that may indicate your house may need abated for lead. One of the things we put in our budget is a new lead abatement program that we're funding through Medicaid to do far more houses. So that's a specific thing we're doing. But in general terms, this area is called the social determinants of health, where there are so many things out there in the community that affect health that we really do need a comprehensive approach. Now, what we try to do, though, is stay focused on you can't make that primary care doctor responsible for all of that. But if you can make them more sensitive to establishing partnerships that increase the likelihood a person will get connected to the services they need to be well, that's at least a good first step.
Right.
Thank you. My name is Evan Dubrow. I'm founder of Our Family Home, which is a residential care home for individuals with Alzheimer's disease. You brought up in your opening comments that 4% of there's 4% of individuals or group that receive over 50% of Medicaid. Is that correct? They said that. So we're talking a lot about the others, but let's focus in on that 4%. As we all know, there's a tsunami coming of our age and the age services that we have. You explained that you have a strategy in this Medicare expansion to provide what we call aging in place, and the services aging in place. But in all reality, we know that not everyone can stay at home. There are many factors where people have to move out of their home setting or out of their families or children's homes to get care. Currently, the state of Ohio only allows certain providers to receive Medicaid to serve individuals who need institutional care or facility care. Many states throughout the country allow other providers to receive Medicaid from the state to provide those services. So have you, as a state, in looking into it, look at other providers that are allowed to receive or can be applied to receive these Medicaid services and reimbursement besides the Ohio Home Waiver, which is a small little fraction? And why don't we allow other providers who can do it for less costs, in a better setting, and more dignified, to allow to be part of this system that you're talking about?
Yeah. No, that's a fair question. That's a fair question. And we have had discussions on that. One thing we've tried to do is prioritize each next reform we took to not create confusion. And for example, if the emphasis is on getting dollars out of institutions into home and community settings, while also saying we're going to open up more institutional providers to be able to provide those services, that becomes complicated to talk about in the context of a budget. Now, once you build up the home and community services to a point where we have full capacity and no waiting lists, which on the senior side of our waivers we do, but on the developmental disability side of our waivers we don't yet. That's why we continued putting the emphasis on building up the home and community services. I do think, though, we're getting to a point where we're close to feeling we've right-sized the system and we can ask questions like, okay, now who are the most appropriate providers? So for example, in the institutional side, if there's another type of provider that can provide the same level of service but more efficiently, well, that would be an obvious decision to consider. The other thing we're doing in this budget is taking the long-term services and supports and moving them into managed care. In a fee-for-service program, we have to credential a particular provider so we can pay them for what they're doing. In managed care companies can organize networks with providers they choose, so you can make a value proposition to a managed care plan, and there's no restriction then on them creating a network that includes your provider. So it's one of the advantages of getting out of the fee-for-service environment and into managed care. Yeah.
One question. Thank you, Andy. My name is Karen Twynham. I'm with National Church Residences, and I also lead a group called Loving Someone with Mental Illness at Vineyard Columbus. You mentioned addiction and mental illness are priorities. If the statistics are correct, I'm not the only person in the room with this problem. I have a son with schizophrenia. He's 30. He's a dual eligible. He's been stable on his medication for 9 years and lives in permanent supportive housing. Is there anything in the current environment, in your budget, or in Washington that you think I should be particularly worried about for him?
That's a really good question. One thing that concerns me has been misunderstood, and so I'll take it as an opportunity to answer your question. And I just mentioned the dynamic of, in developmental disabilities, the idea of institutional service and community services. And there's a lot of fear that government will tell families what the most appropriate setting for their family members, or tell individuals, yeah, you can't go there, we're going to make you go here. And recently there have been even some Department of Justice kind of rulings saying in every case institutions are bad and your only choice should be the community. What we've always tried to do in Ohio is build out a capacity so there's a meaningful choice. So for example, if you're in an institution and you want out, but there's no choice, that's not a meaningful choice. You're stuck in the institution. But if you have a high-value community alternative and an institutional alternative, then you as an individual can judge what is best for your needs. We don't think government should substitute judgment for the individual or family in that situation. So we've always tried to create a capacity that will allow people to choose the most appropriate setting. It doesn't specifically address what you're describing, but it's kind of a general philosophy that we try to stick to wherever we're having to prioritize resources.
Wow, what a informative conversation. Let's thank this panel, Greg Moody and Joe Ingles, for the conversation today. And once again, let's thank our sponsors, Ohio Health and the Mount Carmel Health System, for their support. Thank you so much. We hope you enjoyed today's forum. Please know you can always rewatch our forums on Columbus Television, on WOSU through PBS affiliates throughout the state, and through the CMC website via YouTube. We invite you to stick around for further conversation over coffee and cookies, and we look forward to seeing you next week. Thank you very much.